File in acute and chronic central serous chorioretinopathy.
Good morning everyone. Today I am going to talk about global choroidal thickness profile in acute and chronic central serous chorioretinopathy. Central serous chorioretinopathy is a disease that is characterized by serous detachment of the neurosensory retina, often in association with serous pigment epithelial detachment. Gas postulated that increase in the permeability of choriocapillaries resulted in RP detachment and exudation of fluid into the subretinal space. AIOC2020 has enabled objective evaluation of choroidal thickness, and there is lacunae in existing literature regarding global choroidal thickness values, especially nasal macular choroidal thickness profile in eyes with chronic CSC. Our aim of the study was to describe the global choroidal thickness profile, peripapillary, nasal macular, and temporal macular in eyes with acute and chronic CSC. Coming to materials and methods, it was a retrospective study which was conducted between January 2017 and November 2018 in a tertiary eye care center. Study participants were consecutive patients of CSC visiting the retina clinic. Exclusion criteria included patients with media opacity, any pre-existing macular pathology, any disc anomalies, or inadequate image quality. Patients were divided into 5 groups. Group 1 constituted acute CSC patients in which diagnosis was based on typical signs and symptoms and disease duration of less than 6 months with detectable subretinal fluid on SD-OCT as well as leakage spots on FFA. Group 2 included chronic CSC patients in which disease history was more than 6 months duration along with widespread RP decompensation with or without subretinal fluid either associated with or without an active leakage point. Group 3 included resolved CSC patients in which there was no subretinal fluid or skytic retina but had clear documented past history of CSC. Group 4 included unaffected fellow eyes and Group 5 included healthy controls. All patients underwent comprehensive ophthalmic examination. Image analysis was done with spectralis heatable engineering, and choroidal thickness measurements were performed using AIOC2020 images with the inbuilt caliper tool of the software. Choroidal thickness was defined as the perpendicular distance between the Brooks membrane and the choroidal scleral junction. Choroidal thickness measurements was taken on a horizontal section passing through the fovea at the following points: center of the fovea, 1000, 2000, 3000 micron nasal and temporal to the fovea, and 250 micron temporal to the Brooks membrane origin at the temporal disc margin. Coming to results, this is a color fundus photograph of a right eye of a patient with chronic CSC showing RP alterations with correspondence hypo and hyperautofluorescence and infrared reflectance highlighting the RP alterations. AIOC2020 scan of the same eye through the fovea is showing central SRF and peripapillary skytic retina. In this also, AIOC2020 is showing multiple skytic spaces with underlying SRF over the fovea with peripapillary subretinal fluid and underlying pachyvessel beneath it. This is a table which is showing mean age, subfoveal choroidal thickness along nasal and temporal macula in various groups. Here we found out that subfoveal choroidal thickness was more in group 1, 2, 3 and 4 compared to group 5, and nasal macular choroid was significantly thicker in chronic CSC patients as compared to healthy controls and acute CSC. There was no significant difference in temporal choroidal thickness among the groups. Coming to discussion, subfoveal choroidal thickness has been studied extensively in various studies, and normal values can range from 191.5 micron to 331 micron, and Imamura et al. Has reported increased mean subfoveal choroidal thickness in CSC group using AIOC2020. Subsequent studies has also found increased choroidal thickness in affected and fellows eyes of CSC. Hirata et al. Has also studied peripapillary choroidal thickness. They found that inferior choroid was significantly thinner than the superior, and nasal choroid was significantly thinner than all other areas. Yun et al. Had studied peripapillary thickness in eyes with acute CSC. They found out that subfoveal choroidal thickness in CSC and fellow eyes were thicker. Even nasal choroidal thickness was also thicker in CSC and fellow eyes as compared to the normal controls. So hyperpermeable choroidal vasculature leads to increased choroidal hydrostatic pressure and choroidal thickening, leading to pigment epithelial detachment, causing subsequent RP defects, causing focal leakage into the subretinal space, resulting in CSC. There is one study by Lee et al. Which has described the presence of lamina cribrosa defects or the disinsertions as a potential source of intraretinal fluid extending from the disc with pachychoroid disorders. This study has proposed that a thickened choroid could stress the optic nerve head margin and lead to lamina cribrosa defect or disinsertion leading to intraretinal fluid accumulation. However, limitation of our study included it was a retrospective study and choroidal analysis was compared with control eyes using only a single line AIOCT scan passing through the central fovea. So we require future prospective and longitudinal studies with comparative OCT scans in all quadrants will be valuable to elucidate the exact pathophysiology. Coming to conclusion, this study adds to the understanding of global choroidal thickness profile in eyes with acute and chronic CSE and highlight the differential choroidal thickness profile in these disease entities. I have nil financial interest. These are my references. Thank you for your patient listening.
So you found that the nasal thickness was more.
Yes.
Was the CSR leak also in the nasal part?
Most of the patients had leak on the nasal part as compared to the temporal, and like in
Have
the
the other study also compared the location of the leak? Let's say people are saying nasal is more. So are all the CSRs nasal? That's why.
no. They were temporal leaks also, but majority of them had a nasal leak, like
So
temporal
have
to
you
the.
correlated that in detail? Like, is
That-
nasal leak leading to more nasal thickness or?
No, we actually that only that we that's why FFA and ICG collaboration. If we can do that, will be better. So
Yeah,
this
because
is
you know
only
wherever the
OCT.
leak is, if you say nasal thickness is more, then where is the leak? Is the leak
Yes.
temporal or is it nasal?
Yes.
And since you are saying healthy means not there,
Yes.
and in nasal it's there, but we don't know where the leak is.
Yes.
So it's difficult to.
So actually, sir, FFA ICG could not be done in each and every patient.
Yeah.
That was the main limitation of our study.
Yeah.
Yes.
How did you decide the number of subjects in group 4 and 5?
Actually, sir, we just analyzed the data which was available to us in the, and
But
depending,
normal group 11 patients, subjects,
yes, that we,
and other eye 22 subjects,
Yeah,
and
that
total
is
number
there.
of patients so huge. How do you come to that numbers?
actually, sir, lot of images we had to exclude because of the poor image quality, and we were not getting the proper choroidal scleral junction where we could measure it very well. That was a major
In normal
limitation.
individual?
Normal, actually, we could have taken more data.
Just like
Yes.
You have to
Yes.
better strengthen your data.
Yes, sir, that I think we should have taken.
Normal case you can get plenty.
Thank you, sir.
I now invite Dr.